Everyone, and thank you for joining us today for the next installment in the CD Howe Institute's webinars series on Beyond Algorithms, AI Solutions for Canada's Healthcare Challenges. And today's event, we will be hearing from Ryan MacDonald, Director of Health AI Implementation at the Vector Institute, and Dr. Nicole Mittmann, Chief Scientist and Vice President, Scientific Evidence, Methodologies, and Resources at Canada's Drug Agency. Today's event is sponsored by Johnson & Johnson, and it is my pleasure to introduce Geneviève Lavertu, the Director of Government Affairs and Policy, MedTech Canada for Johnson & Johnson, to introduce our speakers more formally. Over to you, Geneviève.
Thank you very much, Rosalie. Can everybody hear me? Okay, good, thank you. So as Rosalie mentioned, I'm Geneviève Lavertu. I'm Director of Government Affairs and Public Policy for Johnson & Johnson MedTech, and it's my pleasure to welcome you today and say a few words about why J&J is so interested in fostering this discussion on artificial intelligence in healthcare, and also to introduce our esteemed speakers today. So if we take it back to where J&J is already active and using artificial intelligence solutions, I'll give you just maybe 4 use cases where this is currently being used so that you can have in the background some examples, as well as the ones that the speakers will be speaking to. I'll have 2 examples for Johnson & Johnson Medical and 2 examples for Johnson & Johnson Innovative Medicine. So starting with J&J MedTech Digital, we're using artificial intelligence in the operating suite for operating room efficiency and physician learning. So we've developed a suite of digital solutions for the OR called the Polyphonic Digital Ecosystem, and it uses AI algorithms essentially to cut a highlight reel of operating room videos in a matter of minutes. And normally this would take hours and sometimes even days to complete. But with this system, which we're starting to deploy, we essentially use Polyphonic for 3 use cases, with more coming. One is telepresence. The second is surgical video, so editing those videos automatically for sharing between residents and peers for post-case analysis and learning opportunities, and for planning. Second example for J&J MedTech is in cardiac ablation. We use a mapping system called CARTO system, and it enables electrophysiologists to create 3D maps and navigate inside the heart on imaging during atrial fibrillation catheter ablation procedures. The newest software version is the one that incorporates a deep learning. It's a subset of AI capabilities designed to help doctors to deliver effective and efficient procedures and generate valuable case data that can help further improve patient outcomes. And there's more in development in terms of this type of recommender systems. We use it with our Monarch bronchoscopy robot in lung cancer to analyze images and suggest a path for the catheter to navigate through the bronchi of the lungs for hard-to-reach suspect nodules. And that makes it more easily accessible for nodules that would be hard to reach through a surgical approach. And it allows us to biopsy and stage those nodules. So in short, these are some of the 2 or 3 examples. Why J&J is so invested as well in advancing the regulatory science that goes along with this. For instance, with the introduction of predetermined change control plans. So if you're into AI, you've probably heard about these developments. And then a couple more examples that are for relating to J&J medicine. So we use it to speed up the process of discovering new medicine by analyzing huge medical data sets to identify targets. And then once those promising disease targets are identified, we then leverage AI to help discover the molecules that could interact with that target. And we do this with our own technology, but also in partnership with external collaborators. And then the second example for innovative medicine would be to enable more targeted clinical trial recruitment. And that's been really one of the big successes to apply AI and machine learning algorithms to large de-identified data sets to locate the specific clinical research sites that have patients that could potentially benefit the medicines that are being studied. And our clinical trial operations can work to determine the likelihood of enrolling and the speed of enrolling with those newly identified sites. So our goal with this is to leverage the power of AI to bring clinical trials to more patients rather than waiting for patients to come to us in those studies. So one of the added benefits is that through this method, it's also helping researchers to diversify clinical trials because these advanced analytics are finding locations and healthcare institutions where diverse patients are more likely to be treated. So it allows us to calibrate to the kinds of populations that we actually want to be representative rather than the type of patients who would usually flock to the usual suspects in terms of participating sites. So this would be use cases to frame the discussion today. And without further ado, I would like to introduce your esteemed speakers. Ryan MacDonald is the Director of Health AI Implementation at the Vector Institute. The Vector Institute is one of Canada's 3 national institutes dedicated to research and application in the field of AI. And Ryan and his team work closely with healthcare institutions and providers to enable health AI deployment in order to improve patient outcomes and care delivery. Before joining Vector, Ryan worked as senior manager in KPMG's healthcare practice in management consulting, focused on transformation in the health and social care space. He has led teams supporting system-wide digital and operational transformation in Canada, the United States, and the Caribbean. Ryan has a Master of Public Policy from the Monk School of Global Affairs and Public Policy at the University of Toronto, and has gone on to do certifications at Cornell, at MIT, MIT in data analytics and AI. Our second speaker will be Dr. Nicole Mittmann, who is Chief Scientist and VP Scientific Evidence, Methodologies, and Resources at Canada's Drug Agency. In her Chief Scientist role, Dr. Mittmann is responsible for ensuring that CDA, formerly known as CADIP, actively learns, ensures rigor and quality, mobilizes evidence, and links science to strategy. In her scientific evidence, methodologies, and resources role, Nicole leads CDA's shared science groups, including Science and Methods, Health Economics, Research Information Services, Publishing, Early Scientific Advice, and Real-World Evidence teams. And in her academic capacity, Dr. Mittmann holds an MSc and PhD in pharmacology from U of T and holds a faculty position as assistant professor at the U of T in the Department of Pharmacology and Toxicology. She's cross-appointed to the IHPME, Institute for Health Policy Management and Evaluation, and she's also an associate scientist at Sunnybrook Health Sciences Centre in Toronto. Dr. Mittmann has conducted and collaborated on notable research in the areas of economic evaluations, outcomes research, and drug patient safety. Research methodologies include the examination of large databases, economic methodologies, and decision analysis. She likes to link, leverage, and liberate data and evidence. So without further ado, I'll turn it over to you, Rosalie, to moderate our panel today.
Perfect. Thank you, Genevieve. And always exciting to hear about what's in development and being launched with J&J, as well as what our panelists are working on. Just before we get started, I will do a couple housekeeping issues just for our participants. as we will hold Q&A until after both the panelists have given their remarks. And if you would like to ask a question, please enter it in the Q&A panel. It should be at the bottom right of your screen. And if it isn't, click on those three little dots and that should be an option. As well, I would like to just remind everybody that normally the CD Howe Institute events are off the record, but for this webinar, we are in fact on the record. I will do what I can to, not necessarily name names for the Q&A, but just a reminder for everyone that this is on the record for today. And so I'd say that's it for housekeeping. And without further ado or gilding the lily, I will pass it over to Ryan.
All right, can everyone hear me and see my screen? Okay, see some nods. Okay. Thanks everyone, and really honored to be speaking with you all today and being alongside Dr. Mittmann. Really exciting and hopefully a good discussion. I'm going to talk a little bit about what Vector does and the role of AI in healthcare, and then I have a couple of predictions. We're asked to talk a little bit about what we see the future of AI in healthcare looking like. So, and hopefully that can inform a really good discussion. So just a bit of understanding about what Vector is. As mentioned, it was founded in the creation of the Pan-Canadian AI strategy and is one of Canada's three national AI institutes. Vector uniquely is the youngest of those three institutes, but also saw a unique need to be able to say that AI has a unique potential to be able to support people as it relates to healthcare and allow Canadians' health to be improved through the power of artificial intelligence. So you can see the mission statement there. We are an independent, not-for-profit institute dedicated to research and application in AI. We focus on machine and deep learning, and we work with a whole bunch of different partners to be able to do it. In simpler terms, our mission is to ensure that Canada can win in terms of being a leader in AI. Now, I'm sure those who are joining this call are not unfamiliar with some of the challenges that are facing our health system, and they're numerous. We have Canadians are living longer. We have demographic change that is occurring. We had health workforce shortages that happened before the pandemic that have intensified significantly. We have an overburdened system that is struggling to be able to manage a limited pool of resources. And we have a higher set of expectations, both around equity and accessibility, but also for experience and digital transformation. For once, at one point we were excited about being able to have things on our phones and make things easier. Now that is no longer an exciting reality. It is an expectation. And I am by no means making the case that the artificial intelligence is the solution to every single one of these problems. There's certainly legislative policy, models of care, and many scientific solutions that come through that will be critical to addressing these challenges. But when I look at what the areas that AI is good at and has the opportunity to be able to do, there is a direct connection from the opportunities and challenges that our system is facing and the opportunities that artificial intelligence presents. In terms of what Vector has done over the last 5 years, I mentioned that we uniquely put in our mission statement that we were focused on supporting AI, or supporting the health of all, using AI to improve the health of all Canadians. And we've done a whole bunch of really cool and interesting pockets and pilots and successful initiatives over the last number of years. And by no means is this exclusively Vector. This is Vector and partners. Whether that be the incredible team at Unity Health Toronto in their development of ChartWatch, that has led to many hundreds of saved lives, that has now gone on to be commercialized through a company called Signal One, founded by Vector's co-founder, Tomi Puutinen. as well as the Gemini database, which includes over 80% of inpatient beds in Ontario, making it one of the largest AI and ML databases in the world at this current stage. There are many successful stories, and I'm happy to talk more about them in the Q&A as to where we've seen success. But what I would also say with this story is that there are so many more challenges to come. And while I'm excited about the kind of smattering of pockets of excellence that exist across our system, the real benefits that we're going to see over the next decade are going to be driven by opportunities to drive scale. And that's where Vector's focus is, and that's where I hope this discussion will go for the remainder of our time. We were asked to produce a couple of predictions off the top, and I thought about 5. And I think the first is that we're at the beginning of an inflection point. I think most people are really excited about the opportunity that AI presents to be able to improve clinical care, to be able to make better experiences for patients. And that's true. And I think people are really excited about the opportunity to improve provider experiences. That's also true. Researchers, also true. But I think one thing that goes unsaid is the dramatic opportunity that this has from a public finance perspective. You have, and which I know this is an area that CD Howe is always interested in talking about. There was a report earlier this year that between 14 and $26 billion could be saved this is a report by McKinsey, by just scaling the existing tools that we have in play. That is an order of magnitude opportunity to be able to improve both our health system and many other parts. That's equivalent to the entire Ontario education budget. This is 6 times the amount of the Ontario deficit. Huge opportunities. Knowing that I'm running short on time here, we want to get to questions. I'll run through these very quickly. I think health data, it needs to be viewed as a national strategic asset as opposed to what right now we at times tend to hoard it. I was speaking with a founder of a company that a really fantastic radiologist last week who started a company 5 years ago, and he actually said it was easier to access data 5 years ago than it is today, primarily because organizations and institutions are seeing data as an asset. I think we need to think about this as a commodity. We want to liberate this infrastructure to be able to drive new opportunity. Third, I'll just say the landscape is evolving. AI talent needs to become multidisciplinary. Vector recently released a report with the Conference Board of Canada, and found one of the most in-demand skills is people with deep domain expertise who also understand AI. I think that's incredibly important. 4, I'll say, is that I think the economics of digital health are going to change. Systems of record are currently a huge part of our budgets in terms of digital health transformation. And the cost curve on LLMs will dramatically influence this. If we have the ability to have a high degree of precision in being able to leverage unstructured data and inference costs are going down, we will be able to bend this cost curve if we get the appropriate incentives correct. Finally, I'll just share before I pass it over to Nicole, I do think that the patient and provider experience has an opportunity to be really dramatically reimagined. Multimodal models, so vision language models, multi-agentic systems have a real opportunity to take some of the latency that exists in our system and make experiences better for people and that are working in the system and those experiencing it. So maybe I'll stop there and I'll pass it over to Nicole, and happy to talk a lot more in the question.
Well, and thanks so much, Ryan, and thanks. My slides are coming up. So I thought I would, and first of all, thank you for the invitation. It's lovely to be here and really talk about some future thinking instead of everyday operations. So that's lovely. Maybe, what's interesting is both Ryan and myself have taken the perspective that we're not actually at the bedside seeing the patient in the way that, Genevieve talked about the devices that will have direct impact to patients, but the work we do is maybe foundational to allow this to actually impact patient in a different way. And you'll see that with my upcoming predictions. I just thought I'd introduce quickly to Canada's Drug Agency. We're a new agency, a new organization as of September of 2024, built on an existing organization. So next slide, please. And we're funded by the federal government, the provinces and territories, ministries of health, with the exception of Quebec, and we receive funding from manufacturers who submit for drugs for our reimbursement reviews and also for scientific advice. Next slide, please. And so really what we are is a pan-Canadian organization that understands and conducts health technology assessment and really uses explicit methods to determine the value of new technologies that come into the system. And as part of Canada's Drug Agency, some of our new work actually will consider system coordination, data and analytics, and appropriate use as well. Thank you. Next slide. So this is just the background of how we got to where we are today. Next slide, please. And really, this is built on a long history. Our organization has started in 1989 to look at devices and look at the value of devices, and has transformed into looking at not only clinical evidence and economic evidence, but to start to include information on ethics and equity, and also implementation issues, and really unmet need, and really as a sort of a thoughtful approach to understanding the burden of new technologies. Next slide, please. So we sit in a place in between the regulator for folks just to understand the ecosystem of the Canadian landscape. Health Canada does the work to approve and ensure that drugs are either safe or would work. And then we have on the other side of the spectrum, the payers, or our federal, provincial, and territorial decision makers and payers. As you know, how our healthcare systems are provincially and territorially organized. And we sit in between those two those two sort of ends of the spectrum to determine the value of those technologies. And we use evidence really and look at different kinds of evidence to understand what the value of a technology is. And I state, an evidence from clinical trials, evidence from real world evidence or observational studies or databases, evidence from patients, evidence from clinicians, and then also for evidence that's quantitative or qualitative, really important evidence variables that will move or help us understand the value. And then the decision makers trust that we've done the right job. And at the end of the day, and now we're thinking about evidence in the form of where artificial intelligence comes in. Next slide, please. And so this is the kind of work we do now, just for get people on the same framework. How effective is a new drug and or technology compared to existing? And then what is the value to patients? What is the appropriate price? What are the barriers for implementing in the system? So all of those things, as we start to think about what is the future and how can AI help us with that future, can influence and provide the evidence required. Next slide, please. So this is, sort of what we do, and I've already been explaining it, is the value assessment. Next slide, please. So if you want to hear more about it, you can always look at this 3D barcode. But the next slide talks about my predictions. There we go. And so as I think about, the work that we do at the organization is we provide guidance. We look at appraisals and evaluations, and then we actually look at different technologies. So the technologies that Genevieve talked about at the beginning of the session were, these would be technologies that we might review as an organization to understand what's the value. So then what kind of questions do we need to ask? What kind of tools do we need to have? And what kind of guidance is required? And some of our sister or partner organizations around the globe, for example, in the UK, NICE, have just come out with AI principles for in the health technology assessment space. And so what does that include? How to use it? What are the expectations? It's really often about what happens if we have a health economic model that's generated through AI principles? Or what if there's a synthetic cohort because we couldn't run a clinical trial in a rare disease population? So how do we ask those questions? And this is the world of our health technology assessment, is moving into this space to ensure that we are prepared for seeing those kinds of new pieces of evidence that are coming through different methodologies. And we need to ask those particular questions. Maybe I'll add then, so as I predict in the future, and Ryan talked about patient exposure and enhancing the patient experience. The other thing might be improved patient access, right? I mean, we have navigating the healthcare system is complex. It's forward and backward steps, corners for people, processes that and information needs, information gaps, language barriers, understanding where things are all linked up. And, even as simple as, can I pull a lab test to help inform decision-making along the way? What are clinic visits? How do we put this all together in this complicated piece? We all do it very manually now. And there might be an opportunity, to think about wait times and open centers and locations differently. And that's different than a clinical outcome that Genevieve was talking about in terms of stents or any of the other kinds of, or finding patients through RCTs. It is actually maybe managing a system better. And so if AI can pull off, these complex pathways and processes and pull them all together to enable patients to access care in a different way, that would be really helpful. Maybe better management of diseases. As I think about diseases themselves, what's the best way to diagnose, screen, and manage patient care, lab testing, as you think about the whole trajectory of patients being diagnosed at first and then being treated for their particular disease. Is there an opportunity for these tools or AI devices to help identify diseases earlier, screen differently, detect things radiologically where we couldn't detect things now, so that you can get patients early in their trajectory? And then perhaps even that, as Ryan indicated, the bending the curve might be something there. Maybe the enhancement, not replacement of humans. I think when we look at evidence or when we think about medicine itself, it's very complex. The healthcare system is complex, but there are some things that are routine, right? There are some things that maybe are not as routine and might be strategic or might be more complex. And is there an opportunity to take away some of the routine kind of functioning and push those routine and templated kinds of agendas over into something that could be automated, excuse me, and then help move the system over and have complex technologies being used by humans who could actually navigate through a system in a different way. New types of evidence with decision making. So when we look at, as mentioned already, the different kinds of evidence, how do we appraise it? What questions do we ask? What kind of study designs are a part of this? Who is included in these algorithms, and how was the algorithm created? Are we creating inequity by only looking at some kinds of cohorts versus others? And as you know, we like to look at equity in the Canadian landscape and ensure that patients have equal access or equitable access to care. So if they're not included in these data sets or in the training sets, or how do we ask those questions, and how will we even know if the answers are apply to that particular patient population? I think it is a conundrum when AI pops up. We want it to mimic sort of human behavior and be faster and better, but we also want it to make sure that it's representative of the work. And maybe the final kind of targeted sort of care and prediction would be a different way of approaching or using AI. It could be personalized medicine, finding in the clinical trial space. We heard Genevieve talk about finding the right patients, finding the right targets, finding the right receptors. There's also how can we start to look at them and then predict what their outcomes are and leverage the information in all of these large data sets. And AI could potentially identify these patients through medical records like the Gemini project that Ryan talked about, or through clinical trials with other programs that are out there, and feed data in from a number of sources so we can eventually get the right patient to the right kind of treatment and or study required. And so maybe I'll just stop there and go on to the next part where there might be some questions.
Thank you both. And I love this visioning for the potential future of what, let's just skip past all of the implementation challenges, thinking about it for a second and think about where we could be, what that healthcare system could look like. And I think that that's it's an inspirational, motivating framing. And I'll just remind everyone that's joined us today that if you would like to ask a question, please do put it in the Q&A box. And just, maybe as we're waiting for people to type their questions in, I'll just say, Ryan, you really talked about implementation and scale as being sort of the next major maybe roadblock or challenge. And so maybe if you could just say what you at Vector, with all of the pilots you've managed, what have you learned as sort of the things that lead to a successful project moving forward, that could, or factors that could help us with scaling some of these technologies across provinces and eventually nationally?
Yeah, I think it's a good question. I would probably put 4 things out there that are critical ingredients for us. And those would be talent, data, compute, and maybe those. What was my 4th? I'll get to my 4th. I think first, related to talent, like it's going to be an ongoing challenge. Organizations, and I think particularly public sector organizations have spent a lot of time kind of outsourcing a lot of expertise related to digital and technology. And I think we're coming into a world where we need deep interdisciplinary expertise in these spaces for us to be successful. I came from a consulting space prior to my time at Vector, and while I think that the consultants and technology organizations absolutely play a role, we also do need the in-house capabilities to be able to do that well. I think liberation of data is going to be really important. We spent the last 20, 30 years in healthcare really focused on this concept of data minimization. And while that's important, and I'm absolutely think privacy enhancing technologies are critical to ensuring a high degree of trust in our system, it also is counterintuitive to the fundamental how AI gets better, which is more data maximization. So how do you liberate that data in a way that is going to preserve the individual person's privacy, using things like synthetic data sets, using things like ways to be able to mask a person's individual identity? I think really important. Compute, I think, is another piece. Like we need to ensure, and the government has made significant investments in this space, I'll say, very recently. But both on-prem and cloud compute will be critical to ensuring that as we have more computationally heavy models, that we're able to leverage them, and our entire health budget doesn't end up with one of the cloud service providers. I think we need to think critically about what that strategy looks like, because some of that is going to have to live within the institutions themselves. And the last thing, which I remember I did it for, was governance. I think AI governance is an emerging field. There are a lot of great examples of people starting to figure out how to do this well. But I think the open question of when is a model good enough to actually go live is still one that people are grappling with. And part of that solution, I think, is transparency in the performance of your model, and being really critical and publicly saying what the performance of how your model is moving forward. We built a solution for that called Cyclops that does some evaluation. There are many others to be able to do that as well. But I think we also need to be really thoughtful from a governance perspective on how well humans are performing on some of these tasks. If a model only performs, can classify a problem 65% of the time, and you're like, oh, that's not really good. Well, what happens to the other 35%? But a human's only 30% good at that. Well, that's actually a stepwise increase in the capability of the model. So, and we can only really understand that by being critical of our own capabilities as people. I don't know, Nicole, if you have any additional thoughts on that.
Yeah, I mean, you used a couple words that we use on a daily basis at our organization. And so the critical appraisal part is the part we would be interested in, right? So if we're going to see a new technology, what questions do we need to ask? And those kinds of questions are, who was included, right? What did you do? Is this representative? We often ask things like internal validity. What's the bias, right? What is how good was what's the quality of the study design to answer a question? And then external validity is what's the representativeness, right, of the results. And so as you think about I really liked your comment about the governance piece. It is about being transparent, right? How good is it? But how do we know what good means? And I think that that's the piece where individuals who are, at least in my part of the line of business, are really struggling to understand, what does a good evidence package look like if you have a device that has an AI platform, or if you've received something now, a health economics model that was developed using AI parameters, right? So it's almost like, how do we interrogate that data and ask the right questions so that we're not missing something? And I think we do that with all of our work. And recently, like, the whole health technology assessment community has been dealing with real world evidence. So the whole data piece, like evidence outside of a clinical trial platform, we need to ask questions the same way: internal validity, external validity, who is included, who is excluded, what does this mean? And those are the same kinds of questions we need to ask for any sort of new AI, either technology and or any evidence that was submitted, right, to our organization. So the more transparent it is, the better the foundation is, or at least explaining what the foundation is. For folks who did, middle school science report, right? You remember you had to write out what was your objective, what were your methods, right? We're not so sure with AI at this particular time, if it comes to us, how clear that is, right? And how transparent it is. And it would be great to have those kinds of frameworks available for all of us to use. And I can say that we're not the only organization that does this, right? Is trying to anticipate how to ask the right questions. There's a global policy forum that I'm part of, and our meeting in January is all about health technology assessment and AI. And so it is something that is on the top of everyone's mind. And really, how do we just look at evidence in a different way, or how do we ask the right kinds of questions? So we'll rely on folks like Ryan at the Vector Institute and others and associated sort of colleagues to help us frame what does good really mean, and is there a bar, and what does the evidence have to look like in order to be representative, truthful, non-biased, all of those kinds of questions.
And I was like, asking the right questions is always, and also what information you have available to answer them is a critical piece. And actually, the question we've got in the Q&A kind of asks for a bit of an extension. How do the panelists envision the incorporation of peripheral data sets for refining diagnosis and care? The example they provided was the correlation between missing payments, so maybe your banking information, as a risk of, or a flag for potential early Alzheimer's. Thinking about that, I mean, we already have enough challenges unlocking and leveraging the data within the healthcare system, but to really leverage AI, I think a lot of that peripheral data might have value. And so, yeah, how do you envision the incorporation of non-traditional data, and also where does it start? Who should champion it? I think Ryan,
You're on mute. Ryan wanted to jump right in.
Sorry about that. I think it's a good question, and maybe I'll start by answering by pointing to an example. So in Los Angeles, there is the Department of Health there decided to approach the problem of homelessness, big issue, obviously facing a lot of large cities, and Canada not being immune. And they used a federatedly trained model. So for those who aren't super familiar with the concept of federated training, I like to describe it as like when you, back to grade 7 math, when you had two y equals mx plus b type equations, you don't have to give the coordinates for the intersection. You can give the two equations and find the intersection. Federated training of models is the same concept. You can share the model weights without ever actually having to share the private data itself. That is hugely powerful, I think, for this concept of using peripheral data sets, where if you're able to use I think in Los Angeles, they use like utility bills for people that were late on their utility bills, means they probably didn't have funding to be able to pay for it. That had an increase in terms of the probability that they might be precariously housed in the next 6 months. Incarceration data, similarly so, emergency room visits. This traditionally would be a really hard problem to solve because these institutions have different governance structures. Some of them are publicly owned, some of them are privately owned. The idea of sharing those data across this probably scares a lot of people. But I think they were able to use this concept of federated training to be able to share these model weights and make a better prediction. So I do think that there is, and that also has been translated to a unique policy solution where they decided, okay, if we can get really, really precise on identifying the top 500 people that are the most likely to be homeless, let's direct a lot of resources towards these individuals, because we know as soon as they become homeless, the cost to the system is dramatically higher. So I think they basically made it as $5,000 per person. They gave them a case manager and said, what do you need? And some of that meant catching up on bills. Some of them meant buying them a transit pass to get them closer to work. Sometimes that meant buying them a bike so that they could do Uber Eats and find a different income stream. So I think part of this is a technology problem. I think part of it is a policy problem and a legislative problem of like, how do you go about liberating that data and finding new ways and new incentives, frankly. There is a potential where you could create markets for these types of data sets and models. I don't know, Nicole, if you have any additional thoughts on that.
Yeah, I mean, it's such an interesting, I mean, the more data you have, the better, right? Like maybe that's what we say. But it's about, what is the right kind of peripheral data? And so it's such an interesting question that, if I think about, we do some of this stuff already rudimentary, right? So if I look at, I'm in the Ontario space, I used to be part of Cancer Care Ontario. They have a symptom screening program called Your Symptoms Matter. And basically everybody who goes to a cancer center before they see their clinician, or even if they do their lab testing ahead of any sort of treatment, they fill out a questionnaire, right? Online and or within the clinic. And it's been around so long, it actually was paper-based for the first little while. And so, but the point of it was to identify, are there people with dehydration? Are there people with depression that really need to be seen in a different way, right? It's a flag, it's a trigger. It allows you to predict, in theory, if someone has a high pain threshold, they're going to be, or a high pain score, they might end up in the emerge. They might need extra care. They might need this, but if you could do it more in a streamlined way, in a different way, you can start to predict how people will look at the healthcare system or will interact with the healthcare system. And then you could plan differently. As Ryan indicated, you could start, he used the example of you could buy someone a transit pass or a bike, but you could then predict if these individuals who are on a certain drug always end up in the emerge for the following adverse events. You might need to train different specialties. You might need to have emergencies that might be separate sort of clinics to deal with them. I mean, there could be all kinds of opportunities to expand on the use of peripheral data and how useful and the utility of it in the system.
Awesome. Thanks both. We've another question taking us on a bit of a different track. Could we get some kind of consumer reports type analysis of AI solutions? Maybe one of the challenges to implementation is just that they are complex to learn and analyze or decide between different potential options, and really what are the limitations? What are these bases? Essentially all of the nitty-gritty detail that CDA does go through. Could that be boiled down in a comparative way for health leaders, business executives, etc.?
Maybe Ryan, I'll just jump in first. I mean, I think part of my job too is science is pretty complex. How do you make it accessible, right? So that the people who are the decision makers or the people in the ministries actually understood what you did without actually making their eyes roll back in their heads, right? And I think is there a way to do that? I mean, I think there's an opportunity for us to really think about the best way to talk about the data. And a consumer's report, whether it's thumbs up, thumbs down, happy faces, I think we're trying to do that already, or we're moving into that space for the way that we analyze evidence now. And we should, since AI or these kinds of technologies might have that kind of evidence, we would continue on in that pathway, right? I mean, is it like the Clint Eastwood movie, What's the Good, the Bad, and the Ugly? Everything has a little bit of everything, right? So how do we put that into something that's manageable and digestible for individuals who are making decisions? So that's something that's actually really on our mind, about how to do that, to make sure that these complex issues are translated into something that makes sense, and that is then you've trusted that the right work has been done to get to, it's not a 3-5 year thesis, it's some sort of briefing note to a minister, right? So you have to really think about the best way to translate that information.
And I would just say that, like, I think it's important to differentiate on like the performance of a model versus a performance of a product, right? You can have super high performing models that have very low utility to the health system. And I would say that that's probably a fear that I have about, as more and more institutions start to think about what's their AI strategy, is sometimes, picking the low risk intervention may feel like or the low risk prediction tool may feel right because it doesn't have a lot of negative repercussions if you get it wrong. But also I would argue that like a whole bunch of investment for a prediction that doesn't actually change significantly how you would go about doing care is probably not all that valuable in the first place. So I think vectors, I've been a supporter of this model card evaluation, of a standard way to be able to look at how the performance of models. But I would really agree with Nicole that there needs to be a true comparative analysis and understanding on the value of the products and how they actually will improve outcomes, because that's ultimately what we're doing this for.
Yeah, and maybe Rosalie, before you go on to the next question, if possible, I mean, I think, we've been trialing some AI tools internally, and the option, like, for example, in our information retrieval, we're doing that in parallel. So it's not just an efficiency question either. It's actually to make sure that we're getting the right kind of information out of those tools that will actually help us with our own outcomes as well. And so when I think about the work that we're doing, some of it is around what tools can enable the work, like, systematic reviews could be, you get an AI data extraction tool and in theory pull that together, but what do you need to know about that tool before you can use it, right? The other piece is around, if there's an AI enabled technology or device, right? What kind of questions do we need to ask? And we fall into the trap of expecting to see the evidence in the same way we've always seen it, which is a randomized clinical trial. And for new devices with an AI component, you may not have a formal, sort of robust evidence platform that we're expecting to see. And we see that already in the genetic testing. You'll have one gene panel that has 100, and a new gene panel comes in and says it has 150. Well, okay, what's the difference, and how do you measure the value of adding those extra 50? We see the same kinds of struggles with looking at AI and enabled technology, because they're so fast, right? They can update algorithms and programs so quickly. How do we ask those questions to enable that, to help us understand how they work?
I was like, oh, you've kicked off so many questions in my mind. Like, I have so many questions for both of you. We could probably have this conversation for like the next couple years, but by the time we were done, there'd be 10 million new AI tools to start talking about. Maybe I'll dig a little bit deeper on some of the critical ingredients you mentioned in response to the first question, is this access to talent, and sort of in the idea between a product and something that has clinical value. Obviously, it's really going to be the people that give care or are in the system that really know what will have the most value. And so I guess, are there strategies where we can meet in the middle between that sort of maybe that technical expertise and then that clinical expertise, and that's where the magic happens? I guess that's not so much a question as a comment, but just sort of maybe I'll draw you both out on that sort of the intersection of our understanding of these things and how it's linked to either the infrastructure that we have to actually do it and that we actually have to implement these things, whether it's the computational power or the talent to really make that magic happen.
So I'll make two comments on the talent. I think one, I'm never, going to say that a standardized form is a solution to a complex policy problem, but I will say that if you ever hear Dr. Mohammed Mamdani at Unity Health talk about the work that they've done to be able to do an intake on new ideas that are coming into their organization, I think that is in its way, in some way, a really critical step in being able to get people to understand how do you prioritize these types of innovations, and it does provide education in terms of understanding, well, what are the requirements and why would we go about doing this? They built this, this intake form so that when people have ideas, they can submit them. They have to have a broader support from their own organization. They have to have had a conversation with the data and analytics team to understand the feasibility of that problem. I think that is critical. And so co-design as a form of upskilling the workforce, I think is super essential. The other thing I would say is I do think there is a broader policy opportunity and space to operate in that is growing professional development for clinicians, but also beyond just the clinical staff, the privacy and legal teams that exist within institutions, the IT teams that are trying to keep their heads above water with new Epic implementations or Cerner implementations. These are not people that have a ton of time in the day to go mess around with ChatGPT or learn the new Cursor AI coding assistant. So I think institutions have to be thoughtful about like what works in medical education, clinical education, and create an intentional priority for these folks to participate in programs that are not just about developing a model. They are about enabling your institution and our broader health system to adopt these solutions, because it's going to take a lot more than just engineers and data scientists and clinicians. It's going to take the enabling functions of our organization to get there.
So can I add, maybe I really like the wording of co-design, and I wonder though if we've missed the patient perspective by just saying like co-design, like at the end, if we're talking about healthcare, the intent is, what is medicine for? To either lengthen someone's life or improve the quality of someone's life. And so having patients involved in that co-design, I think is really important too. What matters to them? What are the outcomes that matters to them? And how does that set up your question? And then how does your technology help you or enable you to get to that answer? And I think that's really critical. And it doesn't help when you have ChatGPT and you run a question through, and one of our publisher here at the organization ran it and did a ChatGPT and wrote a poem for health technology assessment, and then didn't like it and ran it again. Right. And so as you think about it, you keep questioning and you can get a different answer every time. And that's something unusual for science, right? Science is built on continued evolution and hoping that you can replicate, right? The same thing with maybe a slightly different study design or a slightly different patient. Here we might be going off totally outside of that paradigm of replication, which is the foundation of some of the science work that we've all been thinking of and been trained. And so just making sure that we're always we don't forget who, the end goal is, right? Johnson & Johnson is not investing in these technologies without the patient in mind, right? At the end of the day.
Sorry, I was muting myself to avoid echo and then just, muted myself by accident again. And I think this one's probably for Ryan, but I will also say, since we are getting close to our time, maybe you can wrap your answer up to the final question. And any parting thoughts you want to leave us with in terms of what you think the future of AI is. I think it's clear that there's value, and it's there, but there are still challenges to overcome in terms of getting to the inspiring vision that we were sort of talking about with our 5 predictions. So the final question is, have you worked on a project to implement an AI solution in the healthcare sector? Who was involved? What were the tools? And how did it look from end to end? Like I guess an example would be helpful to help visualize how the application, like how actual implementation of an application goes when you implement in healthcare. And so I'll give that one to Ryan first, and also leave it open to you to take the question, answer the question, or give us your parting shot.
Sure. So maybe I'll talk about a project that we're working on with the Gemini team around delirium. So Amal Verma and Fahad Razek, 2 Vector faculty affiliates, and the co-founders of Gemini, work in internal medicine. And one of the great challenges that exists in internal medicine is the concept of delirium. So in particular, hospital-acquired delirium. It is particularly affects older people, and the estimate is that it costs the system about $5 billion a year, and affects about 500,000 people annually. And I think the estimate is that 40% of delirium cases are entirely preventable. But they are, and with pretty simple interventions, like having a conversation with someone, playing a game, going for a walk, taking them outside, giving them some water, social interaction being kind of a huge driver there. The problem is that in a very busy hospital environment, clinicians are not fantastic at being able to identify when delirium is going to occur. Simply because they just don't have the resources and time to be able to spend looking at each individual. So Amal and Fahad had the idea of like, can we do a better job of predicting the likelihood of delirium? And that as a use case actually for the broader Gemini data set. So all these different hospitals across the province are contributing data. Can we predict what is the incidence of delirium within their inpatient internal medicine wards? And right currently the prediction is going to 2 sites. We hope there'll be many more in the near future. And the objective is to get from unit level predictions of here's where your delirium rate is going, and applying broad quality improvement initiatives towards, can you make individual prediction on an individual to say, hey, this person's at high likelihood of delirium in the next X number of hours, going forward and do an intervention. I think the learnings of this experience are aligned with the challenges that I highlighted before, where I think Gemini and Vector are obviously blessed with having a lot of institutional capacity in terms of the talent side of things. So that might not be where our issues lie. But as we start to think about receptor sites, as we start doing predictions at Sunnybrook Hospital, they don't necessarily have that. From a QI perspective, a quality manager doesn't really understand when they're looking at a model performance report if they can understand the results or not. So I think a talent from an interdisciplinary perspective, being able to translate this into normal words for humans is super essential. And I think that interdisciplinary knowledge is very key. The other element that I would just say from a kind of a data perspective and governance perspective is Fahad and Amal, when they talk about Gemini, it is a incredible win for Ontario and the system, especially given that they did this as kind of its own thing. This was not like a top priority political agenda where funding was. It was their and many others brute force, frankly, for making it happen, and ambition. And but I think that they would both say that there were compromises in the creating of it as well. The level of contribution of that data, it's quarterly feeds, not real time. The opportunity for commercialization, not there. There was a clear condition for folks to be able to contribute that data. And I think it speaks to the reality that we got work to do to be able to figure out how do we operate as a system and not a series of individual institutions. And I think that there's promise, and I think about guys like Fahad and Mal and Nicole and others that are really making meaningful progress here. And I think we got to lift those folks up and give them the support and resources that they need to succeed.
I'm all for amplifying the champions. Nicole, what are your final
quickly?
thoughts?
Yeah, very
Yeah,
quickly.
we're at time, but
Yeah,
that's
yes.
okay. I can cut my end.
No, it's all good. I just appreciate, as a joke, there were 2 middle school references in this webinar, so very good. But I think, just piggybacking onto the Gemini conversation, if we can identify delirium and let's say even adverse drug reactions, or the whole sort of idea of being able to predict, right? That means you've changed the trajectory of an individual going through the healthcare system, because you now have better data and better knowledge. That means you've changed the resources required and you've changed outcomes. And, going back to why are we doing this anyway for the healthcare system? It is to improve patients' lives, right? So just thinking about it from that way, you might be thinking about it in like it's a one algorithm, one tool at a time. The overarching North Star is to improve patient lives.
Well, that is a great sentiment to end on, and I will just say thank you to our panelists. Thank you to J&J for your sponsorship and allowing us to have these great conversations. And in the theme of patient welfare, we've got an upcoming webcast on December 2nd with the Honorable Michael Tibilow, Associate Minister of Mental Health and Addictions. So obviously that's not the AI conversation, but something that's critical to the well-being of the patients, those patients that are in need. And so please, join us for that event as well. You should be getting an invite link in your inboxes after this event. And as always, thank you for your support of the C.D. Howe Institute, and I hope you have a lovely rest of your day. With that, we are adjourned. Thanks, everyone.